Welcome, everyone, and I am Kevin Kopis. I'm the Executive Director of the Washington chapter of the Epilepsy Foundation. Welcome to November. November is Epilepsy Awareness Month. I want to point out a couple people here. They're hiding in the back corner. Sharon Cupp is our Regional Executive Director. There's Sharon. And Jessica Veach is kind of my wing person in all of this, so thank you, Jessica. And Dahlia is somewhere. Dahlia is our volunteer manager, so she might be in the back there. Thank you guys for being here and for all of your help throughout putting this together. We put this together every year because we know that education is key, and education is key to your journey with epilepsy or your caregiver's journey with you with epilepsy. It's key to health professionals, and I know we have a handful of school nurses that come to this conference every year. So speaking of which, Lisa is right there. If you're a school nurse, I believe you get clock hours for attending, and Lisa will sign off on that for you. So thank yous. Thank you to our sponsors. They help put on this event, and they are, looks like a lot of you have already spoken with them, but they're wonderful people with wonderful things to offer, and they are set up in that lobby area and just outside. So please spend some time with them. They've got great things to share. One last thing is I wanted to highlight this program. So this is a phenomenal program for adults living with epilepsy, and I'm super jealous of it because it's something that I wish I had at my disposal when I was kind of in the depths of my epilepsy. I would encourage you, if you are an adult or know someone who has epilepsy, to talk to me or Jessica or Dahlia and Bob, who's at our Epilepsy Washington table out front. He went through this program, and so he can answer questions about it, but it is a phenomenal self-management program, and I would really encourage people to take advantage of it. So I wanted to specifically highlight that slide.
Kevin, is it free?
It is free. Better yet, I'm one of the facilitators. Not for long, but it's led by a peer facilitator, so someone who has epilepsy, and kind of integrate their own experiences in addition to a social worker. Also helps lead it also. So it's 8 sessions, and we do it like every Thursday night for 8 weeks. And it's just, I can't say enough about it. It's a phenomenal program. I see people taking notes. So if the agenda piece, for the first time we put notes on the back of that piece, so feel free to take notes. The nice thing about this setting here is you've got the little tables you can pull out and write on. So with that, I am going to introduce Colleen, and Colleen is a volunteer of ours, and she is going to introduce our first speaker.
Good morning. My name is Colleen, and I am the mother of a 22-year-old son who was diagnosed with epilepsy 2 years ago. With thanks to people and appreciation to people like our first speaker, Dr. Michael Doherty, Jacob is living seizure-free. Dr. Doherty serves as a medical director at Swedish Epilepsy Center, where his team has been very active in working on the surgical and medical treatments of epilepsy. He has specific interests in brain stimulation and in endocrine effects on seizures. Dr. Doherty majored in history at Boston University and studied medicine at Tufts University. He later trained as an intern, neurology resident, and epilepsy fellow at the University of Washington. Please welcome Dr. Doherty.
Thank you, Colleen, Kevin, Sharon, Jessica, and the other folks at the Epilepsy Foundation for offering this conference and inviting me to speak. I don't know all of you in the audience. I certainly recognize a few of you from clinic and from working with you. Can I get a show of hands of who here actually has epilepsy? And who here loves someone with epilepsy? And who here has shed some tears about seizures and epilepsy over time? And who here's EEG tech? Okay, school nurses. Wow, we got a huge show of school nurses. That's fantastic. And folks from industry? Okay, well, good. Now I sort of know who's who. Because pitching this talk is a little tricky because there's very different agendas each of you might have out of gaining information from this. So I thought the best way to do this was to start out in telling my story a little bit, because I'm a provider for people with epilepsy, sure, but I'm also a parent of a child with epilepsy. My son Jack has seizures. He doesn't talk. He is 17 years old now, and his genetic diagnosis of what he actually has took me and my team about 17 years to figure out. So I'm well versed in understanding how hard this is and how hard it is sometimes to figure out what's going on and how to treat it. His therapy, like a lot of you, requires constant maintenance and all the frustrations that come with it, remembering to take medicines, going to pharmacy, arguing with pharmacists. Are there any pharmacists in the audience? And getting pre-approvals for things and getting bills that we weren't expecting, and then writing letters about bills we weren't expecting, and prodding our provider team to do things that we wanted that perhaps they weren't wanting to or ready to do. And I know that's something that all of us go through. So with that in mind, in the background on the following slides, you'll see some pictures of my family, but I wanted to humanize it a little bit and personalize it and demonstrate I'm in this with you. My other disclosures, other than having a son with seizures, I apparently got $48 of food from UCB Pharma in 2018. I don't remember that. If you want to sunshine act your providers and see what kind of industry ties they have, ProPublica has a great website where you can see what your physicians are being paid or acting as consultants for companies. So what are we going to cover? Initial visits, what does the provider want to know? Later on we'll get to what I think the patient wants to know, though obviously that's going to be very, very dependent on what is going on. And how can you get the most out of that interaction? Given most of us have a fairly limited time range to see folks in. It's typically a 30-minute follow-up slot or a 60-minute news slot, at least in our adult epilepsy clinic. It helps to navigate the path through a weird environment with someone showing you where to go, and that's where our provider teams come in handy. And that's where the Epilepsy Foundation and others also act to show you how to navigate this. So what do we want to know? In the background, there's a confusing picture, and it'll become more apparent what that is in a couple minutes. But we want to know a brief history of the events and how they started. We want to know what happens during the events, and we're particularly interested in whether the events are stereotyped or not. Stereotyped events allow us to start building a hypothesis about where these seizures may start from, and therefore to focus on what epilepsies trigger those types of events and how best to treat them. We want to know what triggers for the events occur. For many women, for instance, menstrual cycles are triggers for seizures. There are other triggers: sleep deprivation, stress, missing medications, alcohol ingestions. Cocaine, amphetamines, there's a lot of triggers, and that can help us modify behaviors and work on timing of medications and different medication types based on triggers. Birth and early development histories, I think, are extremely important, and they often add layers to our adult epilepsy patients. I mainly see adults, but I do work with children when I'm on call. Birth and early development histories give me and others ideas about parts of the brain that might have been damaged early on that can't electrically charge correctly and that lead to potential risks for seizure. Are there family histories of seizure? As we move through 2019 into 2020, I think 2020 is going to be really, and that decade ensuing is going to be really important for us to know what kind of genetic screening options we have in figuring out what type of epilepsy people have and how best to manage it. We want to know, are you driving? And if so, why? We want to know impacts the disorder has had in your ability to work or focus or remember or develop relationships. We want to know what studies have been done to help work up why you have seizures. And we want to know what medications and therapies have been trialed and why they worked and why they didn't work. And we want to know all of that in about 40 minutes, and then 15 minutes for exam, and then 15 minutes for explaining what we're going to do, and we're already running late in clinic. So that picture is a cliff-dwelling site in Sedona, the Honanke site, and you can see that's our family there in front of a Native American cliff-dwelling house. And the picture on the left is confusing because it had just snowed, and the snow had melted off the top of the cliff and dripped down and then frozen on the trees below, making the whole picture very beautiful and confusing, but just spectacular when we started to reveal what truly was going on. So here's Jack and his mom crossing a stream. Of course, I'm taking a photo, not helping out, but so what will we do with that information? First of all, we're trying to figure out whether the diagnosis that you're coming in is correct, or alternatively making a new diagnosis. What is the diagnosis? We're trying to figure out whether you're refractory or not. And refractory is a term we use for folks who are not responding to their seizure medications for control. And typically, in a very concrete definition, the failure of 2 medications for treatment of seizures makes you refractory. We want to know if you're under or over-treated. Sometimes people come in and they're on extremely high doses of meds, and they may not need them. And other folks come in and think they're doing okay, but they're having 5 or 6 events a week, and we're very concerned that they're being undertreated. The provider should typically then work with you in either explaining what's been done and showing you some of that workup, or explaining what needs to occur with some of the workup. And the 2 main thrusts of our workup are going to be an EEG or an electroencephalogram, where folks paste wires to your head and record your brain waves and look for focal activity or generalized activity that suggests seizure. We also typically want to know what pictures of the brain have occurred and what the MRI of the brain shows. And the reason we use the MRI is it's a very high-resolution study of brain tissue and gives us an idea about structures that look strange. We also want to consider doing blood screenings and lab works to make sure that the drugs aren't too high or too low, or if there's a mix of drugs, which one is high and which one's low. So if we need to raise one, we're going to raise the lower one. We need to sort of build out a plan based on medications, not only in terms of the drugs, but what are the effects of the medications on bodies, liver functions, kidney functions, bone densities, and so forth. The DEXA scan is a study we'll sometimes pursue in folks who've been on anti-seizure medicines for decades. And we know some of the seizure medications tend to change bone strengths, and the DEXA scan helps us assess how strong bone is. So our goals are hopefully similar to yours, meaning we want you seizure-free, we want you side effect-free, we want you employed, we want you loved and driving if that's safe, we want you respected and empowered, and we want you spending a lot of fun time in the kayak fishing, which is one of the things Jack loves doing. And Jack has a particular fondness for water, which always struck me as both fantastic because I love kayaking and fishing, but later on when we finally got his diagnosis, there it was, a fascination with water in any case. Our biggest concern, though, as providers, as epilepsy docs and nurse practitioners and PAs and so forth, is whether or not we're going to get you to seizure freedom or not. And this is a depressing slide in that if you take all comers with epilepsy, about 25% of them we can't get free of their seizures. We can get about 60% of folks free of seizures with management. We can get about 40% are going to struggle on and off with their seizures, and 25% it's going to be really hard. And that number, unfortunately, hasn't really changed in 20 years. Here, this is that number basically in a slightly different study explaining that about 50% of folks will be seizure-free on their first medication, and the next 13% will be seizure-free when they use 2 medicines at once, and the next 3% will be seizure-free if they're on 3 medicines, and the remainder, that bottom star, or the subtraction there, 36% of patients can't control their seizures with medication. So it's between 36 to 40% of our folks need a lot of help. And sometimes we don't get there. If we aren't going to get there, how can we make the burdens of this as mild as possible? And obviously, we're going to try to work with medications that are tailored to the disorder. There's a subset of meds that work well for generalized epilepsy. There's another subset that works well for focal epilepsy. And the two different medication buckets, some of them overlap, but a lot of them don't. And sometimes people come in on the wrong medication and assume they're refractory, and it's a matter of us just working a little bit backwards and figuring out, yes, this is the incorrect med, we're going to switch you to a better one, and sometimes we'll do really well in getting those folks much better. But there is a fair amount of drug juggling that occurs in a population that's not responding well to the medications, and that means that patients come in and complain of feeling like guinea pigs. Has anyone ever felt like a guinea pig where doctors just prescribe more and more medication? You know, a lot of people who put up their hands are unfortunately my patients. So I apologize, Tyler, Brenda, Kelly. So my apologies there, but it's not without reason. We're working our way through, I'm going to spin it, opportunities with different medications. But if you're in that bucket that's not going to respond terribly well, we need to still look for different treatments and trial them. And it may feel like you're a guinea pig. Yes, that's true, but we're there to help you out through that and try and mitigate what side effects we can and reassure you that even if it's Dr. X who put you through all these meds, there's a pretty good chance Dr. Y might do the same. And if we're going to do it smart, we may need to re-look at some of the data and figure out exactly which ones worked well versus which ones didn't and how to juggle those best. Surgery. Dr. Ko, I think, is talking next about surgical options, but in Seattle, we're lucky in that there are a few centers that provide epilepsy care with surgical techniques. And that group that doesn't respond to medications, the refractory group, they become candidates for surgery. And there's a number of different surgeries available, and most of them are pretty intimidating when you look at them up online or hear about them. The idea of going in for a resection of a piece of brain that's generating seizures is terrifying because most of us intuitively know that every part of our brain does something useful, and taking it out is not an easy sell. On the other hand, if there's a piece of brain that all it's doing is triggering seizures, and we can define that area and make sure the risks of taking it out are minimized and that the benefits are maximized, then the argument becomes more persuasive. There are surgeries that involve damaging of tissue, meaning ablative surgeries that are being more and more used, particularly by the team at University of Washington, where a small laser is targeting a zone of seizure generation that's turned on, and it helps coagulate tissue and stop it from being electrically active. Dr. Ko hopefully will be talking more about that later. And then there's a number of stimulator-based surgeries where we use devices to deliver signals to either the vagus nerve in the neck or the deep brain structures in the thalamus, or directly to the edge part of the brain where seizures are coming from, that help mitigate and manage some of the harder epilepsies. And again, I'm thinking Dr. Ko is going to be talking about that in more detail later. So other workup, it gets more complicated. There's some things that we don't often talk about in our first visits But genetic screening is going to be more and more useful. It's becoming cheaper and cheaper, and it's allowing patients and families to focus more on what's relevant to them specifically. There's other issues we have to be conscious of when folks come in with reasons for seizures that aren't all that clear, meaning maybe they had a stroke, maybe they have a state where their blood clots easier, maybe they've got a tumor, maybe they've got inflammatory bowel disease, maybe they have schizophrenia or autism or Alzheimer's, maybe they're pregnant, maybe they're depressed. All of those have Venn diagrams that overlap with having seizures. And those are important things for us to work on as well. This is a picture of Jack pointing at a swimming pool on a road trip we went on, and about every 5 minutes he would point to that swimming pool like, I want to go to the swimming pool, take me to the swimming pool. You know, kids of about age 10 to 12, you know, they love swimming pools, but and that's his brother Sam sort of acknowledging that, yeah, the question is always the same. How are you going to get me better? How are you going to get me to the state where we're doing well? And there's a little provider fatigue with Sam looking at him skeptically, but his goals are always the same. It's not always about the seizure. Studies have shown that in management of folks with epilepsy, it's not necessarily the seizure count that's most frustrating. Sometimes it's the stuff that comes along with it, mood issues, depression, suicidality, anxiety, memory trouble. SUDEP, which are you all familiar with what SUDEP is? SUDEP means sudden unexpected death in epilepsy, and it's really frightening to think about if you care for or have seizures. It's about 1 in 1,000 of our patients every year we lose from a seizure associated or related somehow to their epilepsy event. There's very little we can do to prevent it. It is terrifying. It's I lose 1 or 2 patients a year from this, and it is heartbreaking every single time. And I share that fear with you as a parent and as a provider. It is something we're all very interested in figuring out why people have it, and the extent of why we think patients are at risk for it still falls back on several things like nighttime grand mal or convulsive seizures, medications that got skipped or missed, uses of alcohol or other drugs. And those are the ones we can figure out as risks, but there's a large chunk of folks we can't figure out why this occurred. And that's the area where a lot of us would love to see us incorporating genetic screening into most of our visits when it gets more affordable, so we can define this group earlier that's at risk and work really hard on trying to minimize that risk. What else? Relationships. Seizures make it hard to think about dating. They make it hard to think about caregiving and how are you going to live independently. Having epilepsy is tricky for folks who want to conceive, both male and female, and requires some close monitoring during pregnancy states, or if they're trying to conceive and nothing has happened, working backwards and trying to define whether or not meds were affecting chances of conception or if genetic states were affecting chances of conception. We work on psychological events that mimic or look like seizures. So there's a subset of folks who come in for our monitoring that have non-epileptic events or psychologic events that look very similar to seizures but are not. And we need to understand what they are and make a correct diagnosis so that medications given are not ones that are going to hurt them long term, but that are going to be useful in managing the state. And we need to help folks move towards the counseling or insight-based therapies instead of medical therapies if there are psychological origins to their events. School or job support, advocacy groups, external support, pharmacy insurance, coverage nightmares. These are all things that the Epilepsy Foundation is good at working with you on. as is the Department of Vocational Rehabilitation or the PACES program like Kevin was talking about, but there's other aspects to having this that make it hard that sometimes are more demoralizing than the actual seizures themselves. So what do you want to know as a patient? And this is, obviously I'd love to ask you all what you want to know and hear, but that's realistically not going to work in the time frame here. But in general, what I want to know and what patients ask of me is, what is a seizure? Well, it's kind of an electrical storm in part of your brain, and it's either in a small area or it's in a giant area, and it depends on what type of epilepsy you have, whether or not it's going to turn into a bigger event. Most of the time, the brain is well tuned and working appropriately, and every now and then, the seizure states, like turning an old-timey radio, you get it jogged into the fuzz and the nonsense and the static, and that's what happens during seizure. You get nonsense activity that won't stop firing that causes all kinds of problems. The seizure can vary in its presentation. If it starts in the left motor region, it might give you right arm shaking. If it starts in the right temporal region, it might give you a sense of déjà vu or jamais vu, and then an inability to respond easily. If it starts in the visual region, you might have sparkling and shimmering. So depending on where things start, you may have very different presentations of your seizure, and that's part of the issue if you go to support groups or chat groups, one person's seizure is not going to be exactly the same as the next. People want to know their prognosis, and that takes some time, especially as we're moving through medication trials as to whether or not people are going to respond. Children have a better chance than adults of outgrowing their epilepsy, but a lot of kids won't, and it's going to be lifelong. Most adults with new onset seizures are not going to outgrow them, especially if they're failed one medication. So the prognosis is, for a lot of my patients, you're going to be stuck on medical or other therapies lifelong, and we're going to work on which ones make the most sense for you lifelong. Can my kids get it? Well, if there's a strong family history of your mom and having it, your grandma having it, well, there's a really good chance your kids may have it too. There are certain disorders like neurofibromatosis or tuberous sclerosis where we know the risk of passing seizures on to your kids is really high. There are other more subtle genetic epilepsies that involve sodium channel mutations that might put children at risk if you have it too. How do I cope with it? What's first aid? Can I work? Can I live alone? What are the costs? Why is my memory not doing well? My mood, my sleep, fatigue? And then, can you fill out this paperwork? Which, yes, by and large we can, but the other issues there, obviously everyone has their own individual concerns about what they want to know from the provider. And sometimes it's not necessarily the physician or the nurse practitioner or the physician's assistant who's the one who's going to answer those. Sometimes it's the social worker or the nurse or the Epilepsy Foundation or chat groups or PACES or support groups. So what do we typically not know? We don't know why your drugs are so expensive. This is infuriating for us just as it is for you, because there's medicines we want to use that are good that often are extremely expensive. I know that in the United States a lot of the research costs and developments are born in this country rather than elsewhere, but to me the cost of medications is exorbitant and extraordinarily frustrating. And I'm sure, can I get a show of hands of people who agree? Yeah, so this is a big deal, and this is something that we'll get back to later in terms of how can you help your community in terms of asking for lobbying efforts and coverage and pushing for better political and other motivations in getting meds covered effectively. Why can't we get your long-acting levetiracetam filled? I am not sure. This has been an issue for about a year now where the long-acting Keppras or levetiracetam generics are really hard to fill. I don't know why. It's extraordinarily frustrating for all of us. Why doesn't your plan cover the medications, workups that we want to use? Why does one plan let me see you and another plan doesn't? That's not really your physician deciding any of that, unfortunately. And we try and work our way around that with appeals and approvals and things. But there's a lot of background work that goes into trying to get you on meds and therapies that are expensive. And we're not going to know the latest about what Uncle Joe told you over Thanksgiving about CBD oil, because he's going to tell you it's the best thing ever. You should try CBD oil. And yeah, it might be useful for you, but a lot of the stuff we're seeing in folks who've tried it, it doesn't make a huge difference for a lot of our patients. There's certain groups it does. The Dravet patients and the Lennox-Gastaut patients in the studies do fairly well on CBD. But what we're finding is providers like myself are using CBD oil more and more is it's a tricky drug to work with. It's a very dirty drug in how it interacts with other meds and liver functions and so forth. So it's what Uncle Joe tells you, take it with a grain of salt. Check with us first. Please don't abandon your conventional therapies for CBD oil alone. We've lost 2 patients who did that, and that's highly terrifying for us. So getting the most out of the visit and the relationship. This is a picture of Georgia O'Keeffe's table at the museum, at the O'Keeffe Museum in Santa Fe. And she was a painter. And I don't know any painter that would ever have a painting table that looks that organized. But that's prior to the visits. I try and go through my upcoming days visits with looking at their chart, looking at interval studies that have occurred, digging up old labs, incorporating that into their notes. So I go in somewhat prepared for what's happened if I've seen it in our labs and otherwise. I don't necessarily know, obviously, what happened with all the events if I've not heard about it, but my priority in going into that visit is that I've taken a look and taken some time and tried to figure out what seems to be, from my version of things, what the issue is, and then reassess what actually the issue is when our patient comes in and starts talking. I view this as a two-way street. I think the patients should also come in prepared for the visit, meaning it's one thing to bring your shopping bags full of your medications and show me all the meds you've tried. There's another much more useful way to do it is if you bring in the meds you're actually on with the correct doses that you're taking. So it's a quick comparison to what we have in our record versus what you're taking. That's far more useful. Clarify what you don't understand. I try and do that with going back to the points I need to know about the seizure duration, the triggers, the med side effects, and so forth. But we need you to do that, to ask us, well, I didn't understand what you meant by refractory, or I still don't know what a seizure is. Why do I have this? What are we going to do about it? So clarify what you don't understand, and we'll work on it together. And I like to try and give positive feedback about how things are going, because this is frustrating. It is hard. I like to compliment folks on them doing well or getting some progress here, even if we're still stuck in that 25, 26% super hard to treat group. I don't particularly enjoy or like either one of these responses. You're the doctor, you tell me when we offer a choice, or me telling you, you're the patient, you do this. Those don't really work for me. I want a dynamic where you're coming to me with ideas, I'm coming to you with ideas, and we're negotiating out what seems reasonable and safe. And if we're negotiating something that seems a little bit terrifying, making sure that we have a backup plan if it doesn't work, and making that very clear from the get-go. This is what we're going to do if it doesn't work, and this is why we're doing it. And I know this might be a little bit hard, but let's try it. And vice versa. Patients coming in, you've had me on this medicine for 15 years. I'm doing great. I haven't had anything. I want to go down on the medicine. It's like, I don't want you to go down on the medicine. I want to go down on the medicine. Okay, well, let's reassess your risk and see what it is, and then see if we can build a safe way to move you down. And if it doesn't work, let's make sure we're ready to go with something that does. So we're lucky in Seattle. We have at least 2 level 4 epilepsy centers, Swedish and Harborview Children's. Those 2 programs are combined. An NAEC epilepsy program means the National Association of Epilepsy Centers. It means there's specialty trained providers. It means there's surgical care. There's focused nursing trained in epilepsy, social work that's also familiar with epilepsy. There's neuropsychologists who are familiar with cognition and thinking in people with seizures. There are monitoring wards. There's some here at Children's. There's some at Harborview. There's some at Swedish, both First Hill and Cherry Hill, where we bring folks in and paste EEG wires on their heads and drop their meds and try and elicit seizures to safely figure out where their seizures come from and what happens during seizures. There's multidisciplinary planning for surgical attempts, meaning if I've got a patient I think merits a surgical intervention, I then take their data and I have to convince my team to agree with me. And if they don't agree with me, we add to the plan or modify it so that the whole group has a say in whether or not we're moving forward on a therapy that is intimidating and risky. Certification means volume. It means that we see a lot of patients, so we're not just doing this now and then, we're doing it all the time. It also means standards, where we're submitting documents showing what we do to the NAAC for review, for certification. And it means we're acting as an advocacy group for coverage, for pushing agendas for epilepsy advancement. And it means it's not just, 4 white guys sitting around in a room. It's a huge crew. That's a lot of our crew at last year's Epilepsy Foundation dinner. Other things you should know, if you call in or you're trying to contact your provider about concerns, a lot of those concerns are going to be screened by an epilepsy-trained nurse first, and they're going to try and mitigate and resolve the issue, and if they can't, they're going to pass it on to the provider for their input. So if you're worried about something and it's not going well, your first contact with a call or a MyChart message may well be nursing staff. And those same staff in the background aren't just fielding their calls. They're doing a ton of work on getting meds approved, refills, prior authorizations, appeals. They're pretty much flat out doing paperwork in the background the entire day. It's extraordinary the amount of time our nursing team spends on getting medications approved and refilled. It's just ludicrous. If there's one thing that we wish we could improve for everybody here, it would be coverage and efficient delivery of medications. There's other things that you should know. That electronic medical records are moving very, very quickly. And at least in Seattle, there's one big system called Epic that University of Washington and Swedish both have, which allows us to look quickly into charts for wherever you are that has Epic, not just UW. It could be Mayo Clinic. It could be some of the hospitals out east. But that means we can see a lot of stuff that's been done previously very efficiently, but it's quirky. Some of the labs we order don't appear in the results section. If you don't order the lab, it doesn't appear in your results section. So there's a lot of little quirks to it that may seem like advantages at first, but when you call up and say, no one told me what my labs were, well, true, we may not have seen them. We may not have seen them because they may not have ever gotten routed back to us in an efficient and effective way. So we need patients to be their own advocates on this stuff, meaning, yeah, if you're not hearing back from your provider on some workup that has been done, don't assume it's normal. Assume we're morons and we just don't know where it is, okay? And don't be shy about calling us out on it. It's completely fair. It's appropriate. Because that sort of stuff is tricky and it seems like it should be easy, but it's actually not. Our bad days are often a little different to yours, and most of it's filled with paperwork. And then controlled substances require ever-increasing amounts of paperwork. So what do we mean by controlled substances? There's a few that we use quite frequently in epilepsy. Vimpat or lacosamide is one. Onfi or clobazam is another. Lorazepam, Diastat. These medicines require a little bit more legwork to get to pharmacy, and it adds to and translates to a whole lot more administrative burden with really not a lot of reason behind it, unfortunately. Research. There's a lot going on. You should ask what is offered, particularly if not doing well. A lot of the journals now in the last 5 to 6 years are what's called open access. It used to be when you look up a study, you'd get maybe a little bit of information, a paragraph or two about what the study was, and then you'd have to go down to, say, UW's library and dig through the stacks and actually find the journal. But now a lot of the journals are open access, which means the entire paper can be found online and you can read it, and it may well be all in medicalese, but if you've done some studies and looked at things that you think are interesting for you, and there's a paper there and you've read it and you think it might apply to you, well, bring it in. Let's look it over together. Let's figure out whether it's relevant and whether or not there's something useful there. The open access does allow you a lot more ability to appear at high quality work without needing a subscription to journals. Progress in epilepsy has been way too slow. We're still stuck with that 27% never seizure free. That's 20 years now we've been stuck. And in that time frame, there's been about 10 or 11 new drugs. There's been multiple new stimulator-based techniques. And yet, we haven't moved the needle as much as all of us would love. And that may be because some of those therapies aren't being used, but this still remains a very stubborn disorder. And unfortunately, I don't see it going away anytime soon. We talked a little bit about genetic testing. The genetic testing we did for Jack was a whole exome sequence, meaning they ran his whole DNA and were able to figure out a tiny point mutation in a gene that triggers Angelman syndrome, which we had already screened him for Angelman syndrome when he was 2 or 3, and he was negative. But these point mutation exome screens allow far more detail on stuff that we didn't realize was going on, that give slightly different phenotypes that allow us to then focus back now on the gene we know is abnormal. So I can look up the gene and see who's doing what based on that gene and where they're doing it. And the day after we found out, I was then aware that there's a group at UNC who's doing gene-based therapy trials that are starting to, and it's just very effective ways to look at potentially opening doors that none of us really knew were there. Most new drugs have not turned into marked advances in epilepsy care. And then this is particularly demoralizing for all of us. There's not a lot of neurologists, either adult or pediatric, and there's forecasts to become even fewer in the future. We spend a lot of time, I run an epilepsy internship for undergraduates who want to go to medical school, who are interested in clinical neuroscience. And I bring these kids in because I want to brainwash them into going into epilepsy care. I want to take the smartest folks we can get and get them interested and see how fun it is and interesting it is, so that they're motivated to use their big brains to move the field forward and provide care, because we're running out of folks. This is particularly critical in areas outside of big metro hubs like Seattle. For instance, Spokane is hurting now. They don't have any pediatric epilepsy providers. And Spokane's a big city. Beyond that, Missoula, Wyoming, Idaho, there's very few people in vast swaths of the United States who deliver high quality epilepsy care, and that is really hard. So here are a couple asks of you in tying up today. One is buy a pill box. Oh God, it's $2. This is the best $2 you will ever spend. Good Lord. If it seems like we're pedantic about it, making this request, no, I've missed Jack's meds. I've forgotten them. Who has forgotten their meds before? Right? It happens. We get it. But a pill box can allow folks to see, both you or whoever's with you, it can give a quick peek as to whether or not the meds were taken, which means important decisions can be avoided. If we know you missed the pill and then you had a seizure, well, we're probably not going to change the medication doses or strengths. We're probably going to advocate for whatever we can to get you to take them on time and regularly. And this saves lives and saves folks ending up in the ER and a lot of steps backwards, because everybody here who knows how hard their epilepsy or seizures hit them, when you have a seizure, it feels awful. It's a step backwards. It's demoralizing. It's a constant reminder of what you have and what others don't. So pillbox, cheap, easy, maybe saves a ton of heartache. The second is, this disorder means that you're vulnerable politically, financially, socially. Drug costs are high. We talked about that. There are employment issues. There are coverage issues. There's provider shortages. There's resource shortages. Groups like Epilepsy Foundation, I would view it as, yes, one place to gather resources and web-based information about epilepsy and seizures and so forth, and support groups and epilepsy camp and so forth. But I would also view it as a conduit for you to turn around and ask them, how are we going to get this stuff that's important to us move forward? How are we going to get our drugs covered? How are we going to get insurance companies to take some of this stuff seriously? How do we get employers to make work concessions that allow me to stay employed and feel useful and earn money when I have something that shift work, for instance, makes much harder? So I would suggest that regardless of who you're seeing as a provider, that you too are part of the provider pool in terms of advocating for change and affecting change for you and others in ways long-term that might help us all. That's Jack's team, the Mad Jacks, at the last Green Lake Walk with his brother Sam. They're getting the big hug. We're here to help each other out, and I think I have about a minute or two for questions.
I have 4.
4 questions? Okay.
I'm a nurse, pediatric epilepsy nurse. First question is, you mentioned IBD, irritable bowel disease. Do you think that there's a problem with uptake of the amino acids that create neurotransmitters, and that's why it's related to epilepsy?
So IBD, or inflammatory bowel disease, has a sort of umbrella of various disorders, including Crohn's and ulcerative colitis. And those disorders basically mean there's inflammation in the bowel wall. And there are a couple things happen there. One is that inflammation means there's a systemic or body-wide inflammatory state, and those cytokines or chemicals that the immune system uses to drive inflammation aren't just ending up in the bowel, they go everywhere, including the brain. So IBD makes seizures more likely. If you then turn it around and say, well, gosh, there's a lot of inflammation in the bowel, it means drugs don't get absorbed well, or it means that the drugs move through the bowel very quickly. So a long-acting medicine, for instance, in someone with a bowel that doesn't absorb it, doesn't make a ton of sense. You want something that's actually short-acting that gets absorbed quickly. So the amino acids part, I don't know enough about specifically that to really answer that.
Has VNS been considered as a prophylactic for people who are at high risk for SUDEP? Or is maybe they already have one? And it's
Yeah,
not-
so that's a great question. The studies suggest that VNS does lower the risk of SUDEP. And we use it in folks we know have compliance problems with nighttime convulsive seizures this is the classic example, is young men who like to party and don't take their medicine. And that's a group that I strongly advocate for VNS. You could turn that around and say, what does the VNS otherwise prevent? And the VNS, I think, tends to prevent ER assessments for emergent seizures. It's clearly in my group of folks who have the VNS, their chances of ending up in the ER are way lower. So it has a number of huge benefits other than just seizure reduction. The severity, duration, frequency, and then whether or not you end up in a facility for emergent care.
Mood and memory can also be improved.
Yes.
My last question was about ketogenic diet.
I thought there were 4.
I know, but I realized it's only 3. Thank goodness for everybody. Ketogenic diet, you hadn't mentioned it, but that has proven very successful in certain conditions.
Yeah, so the ketogenic diet is a diet that's mainly fat and protein, and it does help with seizure control. It is a hard diet. Your Uncle Joe, who's advising you to use CBD, probably has also been on keto, but his version of keto ain't the version of keto that we're talking about. We're talking about urine testing for ketosis and a very limited diet with weighing of portions and meticulous attention about carbohydrate content, even in things like pills. So keto is tricky. Most people can't do it. The easiest group to do it in is when moms and dads with kids with hard-to-treat epilepsy have feeding tubes. That's the easiest way to administer the keto diet, but most other people don't last very long on it. Other diets, modified Atkins, low glycemic, South Beach, for instance, use some of those techniques for benefit and are a lot easier to stick with. But yeah, keto does work if you can stick with it and if you're meticulous. Yeah. Was there another? Yes.
I was wondering if febrile seizures have a higher incident of epilepsy later on?
Yes, the short answer is yes. So kids with febrile seizures, so febrile seizures are an issue that infants age 2 to 4 often have. Not all febrile seizures will make that patient then suffer from seizures or epilepsy later, but it does raise the risk. And how we treat those febrile seizures, I've long thought we ought to be doing a trial where we aggressively treat or prevent febrile seizures, not with Tylenol, but with anti-inflammatory medicines like ibuprofen, because of those issues about, say, just what we're talking about with the cytokine release from an inflammatory state. Last example was inflammatory bowel, but in this example, it's a cold or a fever. Can you get the cytokine release down for 48 hours and make the risk significantly lower decades later? So, yeah, I do think that is a very important question, and treating those febrile seizures aggressively with anti-fever medicines that involve anti-inflammatories, I think, is extraordinarily important.
But thank you, Dr. Doherty, and we transition.